of Gondar. Welcome everyone to my presentation on necrotizing enterocolitis. I am Birhanu Alehegn, Pediatrics and Child Health Resident, December 2021. The reference I used for the presentation are from Nelson Textbook of Pediatrics 21 edition chapter 120. Followings are the outline of the presentation, and thank you to be with me. Necrotizing enterocolitis. Epidemiology of necrotizing enterocolitis, pathology and pathogenesis, clinical manifestations of necrotizing enterocolitis, diagnosis, treatment, and lastly on prevention of necrotizing enterocolitis. Key points in the presentation are: biomarkers in necrotizing enterocolitis, pneumatosis intestinalis, primary peritoneal drainage, and probiotics. Necrotizing enterocolitis, the most common life-threatening emergency of the gastrointestinal tract in the newborn period. The disease is characterized by various degrees of mucosal or transmural necrosis of the intestine. The cause of necrotizing colitis remains unclear but is most likely multifactorial. The incidence of necrotizing colitis is 5 to 10% among infants with birth weight least THAN 1500 gram, with mortality rates of 20 to 30% and approaching 50% in infants who require surgery. Both incidence and case fatality rates increase with decreasing birth weight and gestational age. Pathogenesis of necrotizing enterocolitis. Many factors contribute to the development of the pathologic findings of necrotizing enterocolitis, including mucosal ischemia and subsequent necrosis, gas accumulation in the submucosa of the bowel wall, pneumatosis intestinalis, and progression of the necrosis to perforation, peritonitis, sepsis, and death. The distal part of the ileum and the proximal segment of colon are involved most frequently. In fatal cases, gangrene may extend from the stomach to the rectum, what is called necrotizing enterocolitis totalis. The pathogenesis of necrotizing colitis remains to be completely elucidated, but three major risk factors have been implicated: prematurity, bacterial colonization of the gut, and formula feeding. Necrotizing colitis develops primarily in premature infants with exposure to metabolic substrate in the context of immature intestinal immunity, microbial dysbiosis, and mucosal ischemia. An underlying genetic predisposition is being recognized with variants in genes regulating immunomodulation and inflammation. Example: toll-to-like receptor interleukin 4/6, apoptosis and cellular repair. Example: platelet-activating factor and oxidant stress. Example: vascular endothelial growth factor, arginine, nitric oxide. Risk factor for necrotizing colitis. Prematurity. Necrotizing colitis rarely occurs before the initiation of enteral feeding and is much less common in infants fed human milk. Aggressive enteral feeding may predispose to the development of necrotizing colitis, although nearly 90% of all cases of necrotizing colitis occur in preterm infants. The disease can occur in full. Necrotizing colitis in term infants is often a secondary disease, seen more frequently in infants with history of birth asphyxia, Down syndrome, congenital heart disease, rotavirus infections, gastroschisis, and now Lung disease. Clinical manifestations of necrotizing enterocolitis. Infants with necrotizing colitis have a variety of signs and symptoms and may have an insidious or sudden catastrophic onset. The onset of necrotizing colitis is usually in the second or third week of life, but can be as late as 3 months in very low birth weight infants. Age of onset is inversely related to gestational age. The first signs of impending disease may be nonspecific, including lethargy and temperature instability, or related to GI pathology, such as abdominal distension, feeding intolerance, and bloody stools. Because of NEC signs, sepsis may be suspected before necrotizing colitis. The spectrum of illness is broad, ranging from mild disease with only Y-active-positive stools to severe illness with bowel perforation, peritonitis, systemic inflammatory response syndrome, shock, and death. Laboratory derangements may include neutropenia, anemia, thrombocytopenia, coagulopathy, and metabolic acidosis. Hypertension and respiratory failure are common. Progression may be rapid, but it is unusual for the disease to progress from mild to severe. HR signs and symptoms associated with necrotizing enterocolitis, broadly classified as gastrointestinal or systemic manifestation. The gastrointestinal manifestation of necrotizing colitis are abdominal distension, Abdominal tenderness, feeding intolerance, delayed gastric emptying, vomiting, occult gross blood in stool, change in stool pattern, diarrhea, abdominal mass, erythema of abdominal wall, systemic manifestations of colitis, lethargy, apnea or respiratory distress, temperature instability, not right, acidosis, metabolic and respiratory, glucose instability, poor perfusion, shock, disseminated intravascular coagulopathy, results. How can we diagnosis necrotizing colitis? A very high index of suspicion in treating preterm maturisk infants is crucial. Plain abdominal radiographs are essential to make a diagnosis of necrotizing colitis. The finding of pneumatosis intestinalis, air in the bowel wall, confirms the clinical suspicion of necrotizing colitis and is diagnostic. 50 to 75% of patients have pneumatoses when treatment is started. Portal venous gas is a sign of severe disease, and pneumoperitoneum indicates a perforation. Ultrasound with Doppler flow assessment may be useful to evaluate for free fluid, abscess, and bowel wall thickness, peristalsis, and showing necrotizing enterocolitis. Kidney-to-ureter film demonstrates abdominal distension, hepatic portal venous gas, arrow, and a bubbly appearance of pneumatosis intestinalis, arrowhead, right lower quadrant. The latter two signs are thought neonatal necrotizing colitis. Figure showing intestinal perforation. Cross-dotable abdominal radiograph in patient with neonatal necrotizing colitis demonstrates marked distension and massive pneumoperitoneum, as below. The anterior abdominal wall figure showing necrotizing enterocolitis. Plain abdominal X-ray film of an infant with perforated necrotizing pneumoperitoneum. The differential diagnosis of necrotizing colitis includes specific infections, systemic or intestinal, GI obstruction, volvulus, and isolated intestinal perforation. Idiopathic focal intestinal perforation can occur spontaneously or after the early use of postnatal corticosteroids, and indomethacin. Pneumoperitoneum develops in such patients, but they are usually less ill than those with necrotizing enterocolitis. Good, now let's look. Necrotizing colitis. Rapid initiation of therapy is required for infants with suspected as well as proven necrotizing colitis. There is no definitive treatment for established necrotizing colitis, so therapy is directed at providing supportive care and preventing further injury with cessation of feeding, nasogastric decompression, and administration of four fluids. Careful attention to respiratory status, coagulation profile, and acid-to-base and electrolyte balances. Has been drawn for culture. Systemic antibiotics, with broad coverage based on the antibiotic sensitivity patterns of the gram-positive, gram-negative, and anaerobic organisms in the particular neonatal ICU, should be started immediately if present. Umbilical catheters should be removed, but good for access needs to maintain ventilation should be assisted in the presence of apnea or if abdominal distension is contributing to hypoxia and hypercapnia. Intravascular volume replacement with crystalloid or blood products, cardiovascular support with fluid boluses and inotropes, and correction of hematologic, metabolic, and electrolyte abnormalities are essential to stabilize the infant with necrotizing colitis. The patient's course should be monitored closely by means of frequent physical assessments, sequential anteroposterior and cross-dotable lateral or lateral decubitus abdominal radiographs to detect intestinal perforation, and serial determinations of hematologic, electrolyte, and acid-to-base status. Gown and glove isolation and grouping of infants at similar increased risks into cohorts separate from other infants should be instituted. A surgeon should be consulted early in the course of treatment. The only absolute indication for surgery is evidence of perforation on abdominal radiograph. Pneumoperitoneum, present in less than half of infants with perforation or necrosis at operative exploration. Progressive clinical deterioration despite maximum medical management. A single fixed bowel loop on serial radiographs. And abdominal wall erythema are relative indications for exploratory laparotomy. Ideally, surgery should be after intestinal necrosis develops but before perforation and peritonitis occur. The optimal surgical approach, however, remains controversial. The options for surgical treatment include primary peritoneal drainage or exploratory laparotomy with resection of the necrotic intestine and usually stoma creation. 2 randomized clinical trials in the middle 2000 comparing these approaches failed to demonstrate significant differences in survival, nutritional outcomes, or length of stay. A Cochrane analysis combining the results of both trials concluded that there were no significant benefits or harms of primary peritoneal drainage over exploratory laparotomy. The surgical approach depends on surgeon preference and physiologic status. Prognosis medical management fails in approximately 20 to 40% of patients with pneumatosis intestinalis at diagnosis. Of these, 20 to 50% die early. Postoperative complications include wound infection, dehiscence, and stomal problems, prolapse, necrosis. Later complications include intestinal strictures which occur in approximately 10% of surgically or medically managed patients after massive intestinal resection. Complications from postoperative necrotizing colitis include short bowel syndrome, malabsorption, growth failure, malnutrition, complications related to central venous catheters, sepsis, thrombosis, and cholestatic jaundice. Preterm infants with necrotizing colitis who require surgical intervention are at increased risk for adverse growth and neurodevelopmental outcomes. Finally, to prevent necrotizing colitis. The most effective preventive strategy for necrotizing colitis is the use of human milk. It is well documented that newborns exclusively breastfed have a reduced risk of necrotizing colitis. However, because human milk does not provide complete nutritional support, fortification is essential for preterm infants. Some studies have suggested that an exclusive human milk diet using human rather than bovine fortifiers may further reduce the risk of necrotizing colitis. Despite concerns about increased risk of necrotizing colitis with early and aggressive feeding regimens in very low birth weight infants, a safe protocol remains unknown. While extensive data and meta-analyses would support the use of probiotics to prevent necrotizing colitis, clear consensus on the safest, most effective formulation, timing of administration, or length of therapy. Other preventive strategies using prebiotics and synbiotics have also been studied, with variable outcomes. Inhibitors of gastric acid secretion, H2 receptor blockers, proton pump inhibitors, or prolonged empirical antibiotics in the early neonatal period have been associated with increased risk of necrotizing colitis and should be avoided, and treatment may prevent late deleterious consequences of necrotizing colitis. Considerable research is focused on identification of biomarkers for early identification of necrotizing colitis, including torreactive protein, urinary intestinal fatty acid to binding protein, IFAP, Claudin-2,3, a tight junction protein, fecal calprotectin, acylcarnitine, interleukin-6, interleukin-8, and the heart rate. Characteristics: HRC, index Neardenford spectroscopy, NIRS, may be a promising predictive diagnostic modality for necrotizing colitis. Thank you. You can look at my other YouTube channel.